This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery.
And I'm Dr. Ilara, a research fellow. Today we're looking at a fascinating new study from the journal Acta Neurochirurgica, 2026. It's a systematic review and narrative synthesis titled Complications and Their Prevention in Unilateral Biportal Endoscopy, a systematic review with narrative insights and practical management algorithms by Santander, Martin Steenen, and their colleagues.
This is a timely paper, Ilara. Unilateral Biportal Endoscopy, or UBE, has been exploding in popularity over the last few years. It's that middle ground between traditional open surgery and the more constrained uniportal endoscopy techniques. But as with any new tool, even though the concepts go back to D'Antoni in the late 90s, there's always a concern about the learning curve and the complication profile.
Exactly. For our listeners who might be more familiar with uniportal systems, UBE separates the viewing portal from the working portal. It's essentially arthroscopy for the spine. This paper looked at 18 studies, including 8 primary cohorts with over 3,400 lumbar cases, to see exactly what goes wrong and how to fix it.
3,400 cases is a solid denominator. Before we get into the specific percentages, what was the big picture takeaway regarding the safety of UBE?
The overall message is that in experienced hands, UBE is safe and reproducible. However, the authors emphasize that complications are heavily clustered in the early part of the learning curve. They cited RAQ sum, risk-adjusted cumulative sum, analyses suggesting it takes about 30 to 50 cases for a surgeon's complication rates and operative times to stabilize.
That's a critical point for the residents and junior attendings listening. You can't just jump from open laminectomies to UBE and expect the same efficiency on day one. Let's talk numbers. What were the most common hurdles?
Let's start with dural tears. The crude pooled incidence was 2.4%. That's actually quite comparable to open or microtubular surgery, which usually ranges from 2 to 10% depending on the complexity.
2.4% is very respectable, but a dural tear in a fluid-filled endoscopy environment is a different beast than a tear in an open field. Did the authors discuss how to manage that?
They did. One of the main risks for dural tears in UBE is the suction effect or high-pressure irrigation. If you have a small tear, the water pressure can actually expand it or lead to increased intracranial pressure if not managed. Their algorithm suggests that if it's a small kinhole tear, you can often manage it with a patch, like a fibrin glue or a collagen sponge, and then keep the irrigation pressure low.
And for larger tears?
For larger tears, they advise either attempting an endoscopic primary repair if you have the specialized instruments, which is technically very demanding, or converting to a mini-open approach. The key is preventing a post-operative pseudomeningocele or a CSF leak through the portal tracts.
Which brings us to another major concern with any endoscopy procedure, post-operative hematomas. In open surgery, we have the benefit of gravity and drains. In UBE, you're working in a pressurized water environment. What did the study find there?
Symptomatic epidural hematoma occurred in about 2% of cases. The authors point out a specific trap in UBE. When the irrigation is running, the pressure of the water can actually tamponade small bleeders, so everything looks pristine and dry at the end of the case. But once you turn the water off and the epidural pressure drops, those vessels can start oozing.
That's a classic endoscopy pitfall. Did they offer a technical tip to avoid that?
Yes, they recommend a pressure lowering test before closing. You lower the irrigation pressure to near zero and observe the field for a few minutes. If you see clouds of blood appearing, you find the source and use radiofrequency ablation or wax before you pull the ports. They also mention that the incidence of infection was incredibly low, only 0.09%.
0.09%? That's almost negligible. I assume that's due to the continuous irrigation washing out the field?
Exactly. The washing effect is a huge advantage of UBE. It's hard for bacteria to colonize a field that's being flushed with several liters of saline throughout the procedure.
Now, let's talk about the silent complication, incomplete decompression. In my experience, when surgeons transition to MIS, they're so worried about the MI, minimally invasive part, that they forget the S part, surgery. Was that reflected in the data?
It was. Incomplete decompression was actually the most common complication at 2.5%. This usually happens at the far side of the canal during a unilateral laminectomy for bilateral decompression, the over-the-top approach. Surgeons might struggle with the orientation and leave a piece of the ligamentum flavum or a bony osteophyte behind.
This is why I tell my residents that the viewing portal is your best friend. In UBE, because the scope is independent, you can really get it underneath the spinous process to see that contralateral recess. If you aren't seeing the contralateral pedicle or the edge of the far side nerve root, you aren't done.
The paper actually provides a practical algorithm for this. They suggest routine use of intraoperative fluoroscopy or even navigation to confirm the level and the extent of the bone work. They also emphasize that if the clinical symptoms don't match the postoperative imaging, you have to be ready to go back in. The reoperation rate in the study was 1.4%.
One thing that caught my eye in the abstract was the mention of cervical and thoracic applications. As a senior attending, that makes me a little nervous. The cord is a lot less forgiving than the cauda equina. What did the review say about UBE above the lumbar level?
They were very cautious there. The data for cervical and thoracic UBE is still quite sparse. Because these are higher risk areas, the theoretical risk of cord injury is higher. They couldn't even perform a pooled analysis for those levels because the sample sizes weren't large enough in the current literature. The advice they gave? Master the lumbar spine first. Don't move to the thoracic or cervical levels until you are well past that 50-case learning curve.
That is sound advice. Let's talk about the practicalities. If a surgeon is listening to this and wants to start a UBE program, what does this paper suggest is the safest way to de-risk the process?
They highlight a structured training pathway. It's not just about watching a YouTube video. They suggest 1. Attending a cadaveric workshop, 2. Using simulators, and 3. Having a proctor for the first few cases. They also emphasize patient selection during the early phase. Don't start with a grade 2 spondylolisthesis or a massive sequestered disc at L5S1 in a patient with a high BMI. Start with a straightforward single-level lumbar stenosis in a thinner patient.
Wise words. I've seen too many surgeons get discouraged because they picked a nightmare case for their first foray into a new technique. Now, Ilara, the study also mentioned narrative insights. Was there anything about the equipment itself causing issues?
Yes, they mentioned fluid-related complications. Because UBE uses a pump or gravity-fed irrigation, if the outflow is blocked but the inflow continues, the pressure in the spinal canal can skyrocket. This can lead to something called neck pain syndrome in cervical cases, or even increased intracranial pressure. The insight here is to always ensure your working portal is dilated enough to allow for free outflow of water.
It's almost like a plumbing problem as much as a surgical one. You need a sump for that water to escape.
Exactly. And they also discussed the thermal effect. Using radiofrequency or RF probes in a small space can heat up the saline. If the water isn't circulating properly, you could theoretically cause a thermal injury to the nerve roots. So constant flow is your safety net.
Let's recap the big 4 complications for our listeners.
Sure. 1. Dural tears, 2.4%. Manage with patches or conversion. Watch your irrigation pressure. 2. Symptomatic hematoma, around 2%. Use the pressure lowering test before closing to find hidden bleeders. 3. Incomplete decompression, 2.5%. The most common pitfall. Ensure you see your landmarks, the over-the-top approach. 4. Reoperation, 1.4%. Most often due to recurrence or the aforementioned incomplete decompression.
And the bonus stat, infection, 0.09%, which is a huge selling point for this technique, especially in elderly or diabetic patients.
Absolutely. The authors conclude that while UBE has a steep learning curve, the complication profile is very manageable if you follow standardized technical strategies. They've actually included management algorithms in the paper for each of these scenarios, which I think would be great to tape to the wall of an OR for anyone starting out.
It's all about standardization. The more we treat these MIS procedures as reproducible algorithms rather than artistic maneuvers, the safer our patients will be. Any final thoughts from the paper, Ilara?
Just that the evidence is still growing. Most of the studies they reviewed were retrospective and from high-volume centers. We still need more prospective, multi-center data to see how UBE performs in the average community hospital versus these specialized institutes in Madrid or Switzerland where the authors are based.
Spoken like a true research fellow, always looking for more data. But for now, this systematic review in Acta Neurochirurgica gives us a very clear map of the terrain. If you're a resident or a fellow, get into the lab, practice your portal placement, and respect that 50-case threshold.
Definitely. And if you're a practicing surgeon, keep an eye on those irrigation pressures and that over-the-top decompression.
Well, that's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Eris.
And I'm Dr. Ilara. We'll see you next time for more insights into the latest in neurosurgical research.
Stay sharp.
And stay curious. Music out.